Hi, my name is Louise Emmett. I'm a nuclear medicine physician from St Vincent's Hospital in Sydney, and it's my great pleasure to be talking to you today about PSMA in metastatic prostate cancer, and particularly imaging as biomarker. So at this stage, what we have for treatment response in metastatic prostate cancer is bone scan and CT. And as you can see from this bone scan, it is abnormal, but it could be metabolic bone disease. It's very non-specific. It's impossible to distinguish the individual lesions. And because of the diffuse nature of the findings, to identify new lesions would be very difficult on PCWG3. Similarly with this CT, I can tell you that there's a focus of prostate cancer on this CT slice, but you cannot report it as abnormal on the CT due to size constraints. So we've gone from old technology and we need to move to new technology. And the new technology that's really showing great promise is PSMA PET. So with PSMA PET, we directly image the tumour itself and the PSMA receptor. We can identify where the tumour is within lymph node, viscera or bone. We can look to see the total tumour volume, and we can also get important information on phenotype, which I think will have important prognostic and predictive capabilities in the future. The reason PSMA is so good in imaging metastatic prostate cancer is because of its pro-proliferative role in the cell. It's involved in the PI3K/AKT/mTOR pathway, and its expression is increased in metastatic prostate cancer, but particularly in metastatic castrate-resistant prostate cancer. And happily, it holds on, sometimes with just low PSMA expression, but it holds on in very, very aggressive phenotypes, which makes identification of progressive disease possible in the majority of patients. When we look at a comparison of CT, bone scan and PSMA in the staging setting, it's clear that the false positive rate from CT and bone scan at 23% versus 7% for PSMA is just too high. Accuracy at 65% for conventional imaging versus PSMA at 92% is also just not sufficient. So nuclear medicine physicians don't like bone scans. You can falsely upstage and falsely downstage patients with bone scans. It is just not accurate enough, and we need to move on. PSMA PET's got some evidence in the M0 CRPC space. So this is a nice paper from 2019, Wolfgang Fendler et al. They took 200 patients who had defined M0 CRPC, who'd had a PSMA PET, which were then triple read. The PSMA found that 98% of these patients had disease identified on the PSMA PET, of which 55% were M1, 44% pelvic confined, and an overall positive predictive value of 97%. At ASCO this year, the same group have gone on and looked at the 74-month follow-up of these patients. One of the things that they did was they divided the PSMA PET findings into oligo versus poly metastases plus greater than or less than 5 metastases, and found a really nice separation in overall survival and metastasis-free survival when they did that. So number of lesions on PSMA PET in M0 is important. They also found that if they had disease confined to the pelvis, there were much higher rates of local regional treatment, less systemic therapy than if there was distant metastatic disease. So the PSMA PET was effectively informing the treatment the patients received. So where are we at for PSMA PET for treatment response? At this stage, there are no validated, defined criteria for treatment response in the metastatic setting. And this is an urgent need. We need to come up with robust criteria that we can then test in prospective imaging trials in systemic therapy. This is one of the proposals, and they took PCWG3, which is the appearance of 2 new lesions, and also added in an increase in volume of greater than 30% at a site of existing disease, but didn't include confirmation because of the knowledge of the high specificity of PSMA PET. But this is just an opening salvo for an important next step. This criteria hasn't been tested in any clinical trial and would need to be so before implementing into clinical use. Another nice study has come up with a criteria using a combination of total body quantitation, tumour volume, and new lesion identified on serial PET. This is 124 men who had a baseline and week 12 PET while undergoing lutetium PSMA therapy for metastatic castrate-resistant prostate cancer. And what the study found was if you used the criteria of an increase in tumour volume of greater than 20% plus 2 new lesions, the findings were able to well differentiate between patients with progressive disease and partial response, with an improvement in overall survival. So using these criteria, RECIP progressive disease survival was 8.3 months, RECIP stable disease 13 months, and RECIP partial response 21.7 months. They also found that by adding 2 biomarkers, the PSMA and the PSA, improved identification of responders and progressors. You don't just need PSMA PET, you can also use the SPECT imaging that you can derive from lutetium PSMA itself. So this is a study that looked at the ability of lutetium PSMA SPECT quantitation at between baseline and 6 weeks to predict a short progression-free survival. 127 men with metastatic castrate-resistant prostate cancer treated with lutetium PSMA INT. The SPECT images are actually derived from a gamma wave from the lutetium itself, and it's a 30-minute image 24 hours after each therapy dose. So between dose 1 and dose 2, any increase in SPECT total tumour volume was associated with a shorter progression-free survival, 3.7 months versus 6.7 months. And once again, if they added both 2 biomarkers, so used SPECT and total tumour volume, used PSA and total tumour volume on SPECT imaging, progression-free survival for any increase was 2.8 months versus 9 months for the remainder of the population. And that's what these SPECT images look like, and you can see very clearly patients who are responders and progressors. Prognostic and predictive biomarkers. So that nice M0CRPC study that was presented by Boris Hadashuk at ASCO GU also separated patients on the PSMA PET on the basis of the intensity of the lesions, not just the number or the site, but the intensity. And if you had an SUV max of greater than 8.4 versus less than 8.4, then you had a significant difference in overall survival. We know that there's an association between PSMA and the intensity on the primary tumour lesion and histopathology. That was shown very nicely with the primary study at diagnosis of prostate cancer with PSMA PET. And another study looking at the intensity of the primary showed that you could actually differentiate between patients who would or would not go on to get biochemical recurrence based on the intensity or the SUV max of the primary lesion prior to radical prostatectomy, and that was independent of grade group. Looking for prediction of treatment response with lutetium PSMA, some very nice work's been done by Buteau et al., published in Lancet Oncology based on the therapy trial data by ANZUP group. And what they did was they divided patients into quartiles of SUV mean. So SUV mean is a composite of intensity and heterogeneity throughout all the tumour lesions in the body. So it's a quantitatively derived parameter. And those patients who are in the top quartile of SUV mean had a 90% chance of a 50% reduction in PSA in response to lutetium PSMA, while those patients who were in the lower quartile had a 29% chance. So very different response rates. And the interesting thing about the lowest quartile is those patients actually did better in therapy in the lowest quartile of SUV mean if they had cabazitaxel chemotherapy. But quantitation is required to do all of this, and at the moment it's very hard to quantify without the proper software, and most sites don't have the software. So we need the biotech companies to come with us to develop automated quantitation that we can use clinically. There's some data looking at predictive value of PSMA PET in conjunction with enzalutamide and abiraterone in the metastatic castrate-resistant setting. This is a very nice study, just 16 patients, showing that serial PSMA PET, any change, any upregulation of the SUV max was associated with shorter time to change in therapy and shorter overall survival. So patients who had an increase in SUV max between a baseline and a 2-month PSMA PET scan on enzalutamide or abiraterone had a time to change in therapy of 6.5 months compared to 12 and 18 months versus 37 months overall survival. We're going to be looking at a lot of these predictive and prognostic biomarkers in more detail in the ENZP trial. It's a randomized phase 2 trial of enzalutamide versus enzalutamide plus lutetium PSMA with 6 PET scans per patient embedded. We're also going to be doing serial SPECT imaging in this 15-centre study. So in summary, PSMA PET is an imaging biomarker that will be the new gold standard for imaging of prostate cancer, but is not yet ready for prime time and treatment response. There's no long-term role for bone scan in staging or treatment response. M0 CRPC is a multifaceted entity in the era of PSMA PET, and we need to get on and develop knowledge bridges between technologies by embedding PSMA PET into prospective therapy trials in MHSPC, M0 CRPC, and metastatic castrate-resistant prostate cancer. Thank you.